Good evening, and thank you for attending AACP's webinar with Dr. Micah Sadigh, presenting Pain, Helplessness, Suffering, Meaning, and Healing, Guidelines to Clinical Practice. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 50 minutes, followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. The AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE certificate of attendance within 30 business days. AACP's next complimentary webinar will be on December 11th with Dr. Sadigh Shagaldi presenting Introduction to 3D Printing. Our next live course, Evaluating the Occlusion Box, a hands-on view of the complex triad of joints, muscles, and teeth, will be January 31st through February 1st in Scottsdale, Arizona, and all registrants of tonight's webinar will receive a notification when registration opens. I would like to introduce our speaker tonight, Dr. Micah Sadigh. Dr. Sadigh is a professor of psychology at Cedar Crest College, a graduate of Moravian College and Lehigh University. He is a diplomate in Franklian psychology and existential analysis, is also a fellow of the International College of Psychosomatic Medicine, and frequently lectures at national and international conferences. Dr. Sadigh was the recipient of the Cedar Crest College Faculty Award for Excellence in Teaching in 2009 and has authored 5 books, including an internationally recognized book on the treatment of chronic pain and stress-related disorders. His other publications include work on sleep disorders, personality disorders, and treatment of the post-traumatic disorder. With that, I will turn it over to Dr. Sadigh.
Thank you so much, Shay. Good evening, everyone. Lovely to be here with you. I don't know if you're watching this in the morning, at night, whenever, it doesn't matter. Thank you for this privilege of presenting to your academy one more time. I was at your meeting in Spokane a few years ago, met many of you there, and it was truly lovely. Tonight's lecture, just a little bit of anxiety, as I'll be talking about anxiety because I have to make sure I finish this in under an hour. But I have put together a lot of information here for you, and my hope is that, in fact, I'd like to say I can promise this to you that by tomorrow morning, whenever you watch this, the next day you'll be able to apply some of the techniques and procedures that I'm going to suggest into your practice. You'll be able to apply this information. So this is not abstract thinking, although I always like to start with a theoretical basis of practice. So here's the description of my talk. Of course, you'll receive all of my slides and you can page through them. And please feel free to contact me if you have any questions. My email address appears at the end of the PowerPoint presentation. So we are going to look at the different dimensions of pain, especially recalcitrant, refractory pain. And my thesis is that chronic pain becomes so complex and has so many different dimensions that oftentimes this may result in frustration as far as practitioners are concerned, because no matter what you do, it seems like the pain persists. And I'm going to unveil some of those other dimensions, and I assure you already know about them. It's a matter of becoming more conscious of how they contribute to the dynamics of persistent pain. So these are my general objectives, discussing the different dimensions of pain. But also, I'd like to emphasize this has been part of my scholarship. I want to emphasize the importance of meaning or lack of meaning when it comes to life experiences. And I'm going to show you some good research suggesting that that's often um, neglected dimension of treating chronic pain. Life in one word. To me, that word is integration, putting things together. Um, so if we want to work with life, we want to have an integrated approach to whatever it is that we do. So if you want to work with life, we need to approach it from an integrated perspective. So there needs to be an integrated approach to pain management. And I'll just want to emphasize just a footnote. I'm not asking you to um, hire different people to address these different dimensions of pain. It's just more about becoming aware of how these dimensions interact and contribute to persistent pain. Let's start with the International Association of the Study of Pain. This was the 1986 definition, which they have added new components to it, but the definition is a good one and has persisted. And please note that it's an unpleasant pain is an unpleasant sensory and we should not forget that and part and emotional experience. And in a moment, you will see how critical that emotional part is. We're not talking about feelings. We're talking about emotions. We're talking about a massive area in the brain that prepares the brain to deal with a variety of experiences, and that's a very critical part of the our experience of pain. So this is their definition, and I'm going to add another component to it. Um, so an unpleasant sensory and emotional experience which is modulated by a sense of meaning or lack thereof. And I want to emphasize how important it is to explore this meaning dimension. And as you will see, when people feel that their pain is meaningless, senseless, this does not make sense. Why am I going through this? That's when they become self-destructive. And in fact, they engage in maladaptive behaviors that will complicate the pain and its experience. So let's talk about the limbic system. This should be our friend when we talk about pain. This is a massive area of the brain with many components to it. And to understand emotions, the most basic way of looking at emotions is to literally use the word emotions moving us away from pain in the direction of pleasure, or at least away from pain. So this is an older part of the brain that has all sorts of resources available to it. So the limbic system, it's very critical to, I want to emphasize this, I want you to pay close attention to that lower part of um, the limbic system. So the limbic system is not one region, it's actually a stack of uh, uh, different functions and different areas of the brain. And it starts with the hippocampus. And why is that so important? Because it has to do with memory. And I'm like to really take advantage of this just tiny piece of information. When people experience pain, especially when they cannot locate the exact cause of the pain, they tap into their history and start saying, the last time I had this experience, my God, it got so bad, etc. So memory plays a significant role. So I'd like you to make a copy of this slide once you have this slide and put it somewhere in your office, somewhere where you can be reminded to just ask these simple questions. So I'm going to ask you, so this is the practical part of this lecture. Ask your patient, the last time you experienced something like this, what helped? How did you cope with the pain? And please pay close attention. It will tell you, provide a ton of information for you once you have those specific types of questions. As you listen carefully, you will discover that either they approach their pain adaptively, effectively, slow, methodically, etc., or came up with a quick symptom reduction, often maladaptive intervention. So pay attention to what helped and how they responded to the pain. So this is a good time to really listen carefully to your patient's history and provide them with some kind of a hint. So as you recall, a few years ago when I gave those lectures in Spokane, I mentioned that the best way to think about pain, especially persistent pain, is to think of a cube. Now you can add new dimensions to it, but the simplest way is to think of a cube, which I call the pain cube. Now the problem is that we often almost reflexively um, collapse this cube into a two-dimensional structure, and we ask the question, very common, please continue to do it, but we look at one dimension, just the surface of the cube, and we say 0 to 10, where would you put your pain? So just to show you that pain cannot be captured in a 0 to 10 quantifiable dimension, we need to recognize that the absolute immediate response to any pain is actually that of anxiety, which is quickly replaced by fear. So we need to know the difference between these two concepts. Most people think fear and anxiety are interchangeable. They're pretty much the same thing, or one is more of a psychological thing and the other one is like, no, they're not. They're both psychophysiological. They absolutely have a physiology to them, although anxiety has other dimensions to it. So fear is there's one word to remember when you think about fear. Think about known, a known source of threat. So I dropped this bottle on my hand. Now it's hurting, so that's why I'm in pain. Known source of threat, known source of injury, etc. So you seek help, you avoid dropping the bottle in your hand, or try to escape situations in which the same experience may occur. Anxiety, on the other hand, please pay close attention to this. So we went from known to the unknown, and this is a huge part of chronic pain, huge part of it. Known is I dropped this and I'm in pain now. Why am I in pain? How did it start? Where did it come from? Where does it come from, etc.? And that unknown feature of fear becomes anxiety, and you begin to tap into historical data. So physiologically, let's say we have increase in somatic activity, autonomic activity shared by both pain and fear. But gradually that the last time this happened, oh my God, is it going to be that bad again? Oh my, I was in pain for days. I couldn't move my jaw, etc. So anxiety is going to fuel the experience of pain. As you will see, there's an area in the brain that will actually increase the intensity of pain. So it's not here. It's not a nociceptive localized experience. Your brain actually says this could be this and it could be this. And remember the last time such happened. So this can intensify the experience of pain. So the hippocampus, that part of the region of the limbic system, is going to play a significant role, which starts with vigilance, being watchful, hypervigilance, and eventually is I can't control this. It's all over the place, and I'm going to simply withdraw. And you will see the consequences of that approach. So, so doctors, this is what when your patient is asking you these questions. So listen carefully when they say, Doctor, is it possible that this pain is due to, could this eventually cause, etc.? These types of questions, they're trying to turn the anxiety into fear. Remember, fear is known source of threat. Anxiety is the unknown source of threat. So if you say, yes, that's exactly what happened. You broke your tooth. That's exactly why you're having this pain, why your jaw is it's immobilized, you're in extreme pain, etc. You turn that anxiety into fear. Now we have options available to us. We can avoid, we can run away, we can seek help, etc. So those types of questions, they are not there to annoy you or upset you. It's just why do you keep asking these types of questions? It's a desperate attempt to turn the anxiety, the unknown, into the known. So here it is. Yes, this is the reason for it, etc. And you will see their anxiety will subside if you could provide them with um, that kind of a explanation or affirmation, comforting them in some way. And I'm not suggesting to make something up, but just note that anxiety plays a significant role in that whole process. So this is one of my favorite summary of the importance of depression and anxiety when it comes to pain disorder. And I'm going to update it for you, and we're going to bring it into recent decades. So this is the Corp and Simon study, in which they look at pain disorder and whether it's correlated with other forms of disorders such as depression, anxiety, and the combination. So let's highlight the word disorder. So what is a disorder? I'm in pain does not mean I have pain disorder. So by definition, a disorder must cause distress, extreme distress. Number two, it must impair functioning. I can't sit here as long. I cannot walk as far. I cannot type as well, etc. And and the third dimension of disorder is people start behaving in certain ways, adaptively, maladaptively, which eventually are not culturally sanctioned. There's something unusual about the way they walk, they chew, not chew, they eat, et cetera, et cetera. So it's a combination of things. So in this study, when they looked at uh, pain disorder, they discovered that only 8.6% of people with pain disorder did not have any other disorders such as depression, anxiety, or anxiety and depression. And so when you look at this closely, you will see about 32% of these patients, 5,000 people, had actually depression as the component of it, which makes a lot of sense, especially when pain becomes persistent and chronic. Depression it's an absolute component of it. And then 35% had anxiety disorder. And when you combine it, close to 50% of people with pain disorder, close to 50% have a combination of anxiety and depression. So it is very likely that most of your patients have anxiety and uh, depressive features in their presentation. Again, I'm not suggesting to, get a therapist for them, etc. That may be an option down the road. It's more like recognizing what pain is doing to these individuals. And I'll show you in just a few moments how to reduce that anxiety. I'll have instructions for you on how to do it. Just to update you, we can spend a good hour and I can update this. I like this slide because it captures so much so beautifully in one graph. But impact of pain on the course of depressive and anxiety disorders. And doctors, let me just highlight this for you. I actually have this study right in front of me. Um, it seems like we are, in a way, waking up and recognizing the importance of anxiety and depressive tendencies in chronic pain patients. My early part of my career, after I finished my doctoral work, was in I did research on chronic pain, all facets of chronic pain, and after a while, you could see clearly that depression, anxiety play a significant role. And it seems that as we are approaching, so this goes up to 2009, it seems that we are waking up to no, depression and anxiety are important aspects of chronic pain. And now we have ways of measuring this. So the integrated picture of chronic pain, that integrated approach that we talked about that earlier tonight, must include anxiety and depression. Um, so let's talk about the anxiety part and this is something I promise you, if I were to shadow you tomorrow, I'm certain of this, that you actually employ techniques, maybe sometimes consciously, maybe not so consciously, but beautifully, artfully, you apply ways of reducing the activity in this region of the brain, this magnificent region of the brain in the hippocampal network, which actually can increase um, pain levels, can literally increase pain levels. So 0 to 10, if I'm 7 right now, and if you were to increase my anxiety while you're doing a certain procedure, uh, my pain level actually goes up without with no deception, doing nothing else but raising my anxiety levels. So this is an excellent paper. Highly recommend. I highly recommend that you read it. And it talks about think of this as the GPS. One of the GPSs, we have a bunch of them in the brain. It's called it's part of the hippocampal network, entorhinal cortex specifically. Our findings suggest that now, here's the key: accurate preparation information during medical and dental procedures alleviates pain by disengaging. And this is so important, by disengaging the last time this happened. No, no, no. This is not the last time. Please calm down. I'm just going to look at your teeth. I'm going to palpate, your the tissue over here, etc. So disengaging the hippocampus will allow the patient to actually cope with the pain much better. That during anxiety, this GPS mechanism actually intensifies the experience of pain. And please, if you're taking notes, write this down. Time slows down. So if we were sitting and having a drink together, and I'll say to you, how many times has this happened to you that you're doing some dental work or palpating, doing some examination, and the patient says, "Oh wow, doctor, what were you doing there?" It's like you were there for an hour. It's like I was there for a minute, but that brief procedure took forever. Just time slows down when anxiety goes up, when the hippocampal area becomes excessively overactive, amplifies the pain. So actually, the hippocampal formation increases pain. So right there, part of the puzzle to chronic pain is actually in the memory part of the brain, in the hippocampal area of the brain. And so, how would you address this? And I'm going to show it to you in just a moment. One is not to think of pain as a 0 to 10 type of a phenomenon, but to add the dimension of anxiety to it. And there are ways of measuring it. I will show it to you if you like to do research in your practice tomorrow. It'll be very easy to actually incorporate this, but also to be aware of just the fact that anxiety plays a significant role. So here are the practical suggestions that I have. Remember, anxiety is fear of the unknown. The more you make the unknown knowable, the lower the anxiety. No, that's nothing is broken. I see some swelling. I'm going to explain it to you. No, that's not what it is that you're thinking about. The more you try to make the unknown knowable, the lower the anxiety. Anxiety is always, always, always about the future. A second from now, 5 minutes from now, 10 years from now. So if you could help the patient to come back, get closer to now, right there, you begin to um, lower the anxiety levels. Let's not go too far in the future. No, we're not talking about surgery. We're talking about let's do these procedures right now, comforting the patient. Let's stay here. Let's not go way into the future. So doctors, structure reduces anxiety. If you spell out what you're going to do, A, B, C, D, we're going to do this for 5 minutes. Yeah, more structure, the better. Anxiety goes down and it's much more manageable. Here's a summary for you that you can take to work tomorrow or the day after tomorrow is educating the patient to move from the unknown to knowable. Um, and one of the worst things, honestly, if I could tell you, one of the worst things that people do, and I constantly warn my students about doing this, is Googling everything, getting bits and pieces of information, not being able to put together. Before they walk into your office, they're fraught with anxiety, just bits and pieces of information. So educating them is extremely important. Um, focus. No, let's not talk about what ifs. Let's talk about this. So right now I'm focusing on this area, these teeth, um, your temporomandibular joint. Yeah, two of them. Let's work things out, etc. So structure reduces anxiety. Add structure, and you'll see how your patients will respond to that. So this will be a very helpful, immediately practical um, um, with you. If you'd like to do research on anxiety, you can measure a general sense of anxiety versus right now at this moment. It's called state trait anxiety inventory. If you'd like to know more about it, please send me an email. I will gladly send it to you. But this will be very helpful to have some of these instruments if you like to collect data. So let's go back to emotions. Motioning, moving away from pain in the direction of pleasure, or at least move away from pain. Powerful area structures within the brain that help us emote, move away. What if these are not your options? What if you cannot move away from pain? Please pay close attention to this. This pain has been here for a long time. Nothing has helped. We tried this. I can't move away from pain. Clearly, I cannot move toward pleasure. What's going to happen? Please underline this word, helplessness, to me, and I'll be more than happy to demonstrate this to you. Most cases of depression emerge from this state. Helplessness means what I do does not make a difference. So why should I try? Why should I try? Why should I attempt any new procedure? So I begin to withdraw. This is a devastating, very devastating consequence of uh, the inability to gain control of a situation. When people experience helplessness, you begin to see that their motivation begins to change. Even though you tell them exactly what to do, they're not motivated. It seems like they're developing memory problems. And please note in your notes, in your history, you will see um, uh, emotional elements that contribute to hypertension and gastric ulcers. These have directly to do with sympathetic overactivity, which is exactly what we see with um, people in depressive states, and especially when they're experiencing learned helplessness. So, what is helplessness? Erratic, desperate, maladaptive, at times destructive behavior. So, people they try this, that, play with this, play with that, etc. In time, these behaviors become destructive or profoundly maladapted. One is to self-medicate, and the most common one when it comes to pain and a lot of um, conditions in which a person cannot find a quick solution to is to use alcohol. Alcohol is a CNS depressant, and at least for a moment, pain goes away. I'm calm, relaxed. That's exactly how you contribute to worsening of depression, actually, because you're using a depressant. So here we go. I'd like to briefly describe study to you. We can't do human studies of this sort, but this study tells you so much about how to increase serotonin levels, which the levels drop significantly in depressive states, learned helplessness, persistent pain, etc. Well, let's put them on SSRI. This study showed, this is a classic study. They're looking at a group of monkeys, those who have control, those who have no control over their environment. The submissive monkeys that have no control over the environment, being subjugated by the other monkeys, their serotonin levels drop significantly. You can measure this. All they did was switch their roles. So submissive monkeys became more assumed the position of being in control, and immediately, that's the only thing they did. They shifted those positions. Their serotonin levels went up. Sense of control increases um, serotonin availability. Um, and there's another neurotransmitter that I'd love to talk to you about. I can't do it tonight, but perhaps another time. Also has to do with your, uh, not with taking medication, but your how you view a situation. That has to do more uh, meaning, actually. So doctors, the word disability is directly related not only to physical uh, function and lack of function, but it has to do with powerlessness. That's the key to it. And it's a very destructive state. Um, disability means disable. I'm unable to make a difference. Therefore, I am powerless. Therefore, you go deeper into the uh, depressive state. So give them a sense of control, new fonts, give them a sense of control. And my favorite formula is give them small, achievable goals. Please repeat this and tell your colleagues about this. Small, achievable goals. Small, not 10 things to do one thing. I want you to wear your appliance, do it every night, watch them do this. Small, achievable goals. Therefore, now we are adding new dimensions to our understanding of pain, is pain, anxiety, and sense of control. If you like to quantify these 0 to 10, that's fine. But note that flattening that, turning the cube into one dimension, that's actually a mistake. You're missing these other dimensions. My good friend Dr. Barry Glassman likes this slide whenever I bring it up, and I always expand it. So I've added new dimensions to this slide by Lozier. It's very helpful to kind of conceptualize chronic pain. But the last time I talked about the Lozier model, people are asking, like, tell me more about the final dimension of this model. And so I'm going to spend a little more time on that for you. So I expanded the model into a whole different way of looking at it. So pain starts with nociception, a source of injury, painful stimulus. We experience pain, and very quickly, please note, thoughts, emotions, anxiety become a part of that, the dynamic of pain. So again, the last time this happened, it's not going away. Last time it got worse, then I couldn't talk, I couldn't walk, etc., which gradually brings the person into a state of suffering. Very important word to understand. Pain is localized, suffering is all over. It's not all over the way you think, the way you emote, the way you plan your future, think about your past, the way you relate to your loved ones, the way you work. Suffering is all encompassing, just takes over your whole being. And it's all consuming, and suffering gets worse the more meaningless the experience is to a person, the more meaningless. I lost this person, it's horrible, I'm suffering, but now their loss has helped me do good things in their name, in their honor. I have raised money, I've done whatever. You add meaning to um, a difficult situation, when you bring meaning to it, which is very difficult, but can be done. um, Read Viktor Frankl's work in concentration camps, etc., you will see absolutely there's room to introduce meaning to our experiences. So it's this suffering that contributes to extreme sense of powerlessness, which brings about the pain behavior. Pain behavior, doctors, is not something you can medicate or meditate away. It is an incredibly complex phenomenon, and I want to emphasize to you what this thing looks like. So this is my expansion of this model by explaining, ultimately, when we talk about chronic pain, we're talking about this pain behavior, and you've seen it in your patients, and this is something that needs to be modified. Please pay close attention. This is somebody who's having jaw pain. So pain started in the jaw, and now they're tilting their head. Now they're walking funny. Now they're clenching their teeth. Now they're not sleeping well, not eating the wrong things, etc. These are all pain behaviors. These are manifestations of pain behavior. Self-medicating, extreme tension. Now there's atrophy, withdrawal, sleep problems, sedentary lifestyle, misuse of medication, addictions. All these are all aspects of chronic pain. That's the uh, pain behavior dimension. And how do you address these? How do you address all of the above? We go back and number one, most important, to reduce anxiety, make things knowable, add a sense of control. These are desperate ways of gaining control, such as, if I really clench my teeth, the pain goes away. So it's an attempt to gain control, but now you're worsening things. Your posture is shifting. Now you have more tension, you have headaches, anytime atrophy, etc. So if you were to incorporate into your practice one concept you have learned so far, what would it be? If you don't mind, just write down one thing that you've learned so far. I hope it's more than one thing. How would you incorporate it into your practice? The most important thing is to actually become more aware of these uh, various dimensions and to talk to each other. That's extremely important. Other dimensions of pain, honestly, if you ask me if there was one thing you could do to improve pain, single thing, single, you have no other options available to you. I wish I had like three or four, but you have none. I would say improve the patient's sleep. This was a huge part of my career in those early years of doing pain research. And I showed in one of my studies with over 400, 92% of these patients, it should have been closer to 100, suffered from chronic insomnia. Improve sleep, just improve sleep and see what will happen to pain. This is the special slide, my dedication to all of you. It comes from a great, great thinker, um, Ralph Waldo Emerson, one of my great, great thinkers. You can look at anything in life. You can look at anything in life and look at it through three different lenses. Utility. What's the utility of your hand? Things that move things right with it, etc. Sadly, we get stuck on everything. It must have utility. The next level is to actually see not the utility. Yes, there's utility, but the beauty of it. Look at how your digits are arranged, the space in between. There's something unbelievably beautiful about the hand and how it's structured. Anything, your teeth. Um, there's a beauty in that design and that the way things appear to us. And the third level is to look at the mystery. What does it signify? Um, so once you see that bigger picture, once you go into that mystery, your thinking changes. Your thinking changes, and your ability to intervene to help yourself and others also evolves. So to keep looking for the beauty of different experiences and move away from just seeing things in terms of their utility. There's more to life, much more to life. Life in one word, patterns. And let's not forget this. Our physiology is based on pattern. It's almost 9 o'clock here in Eastern Pennsylvania, so it's dark. It's getting darker and darker, and it's affecting our circadian rhythms, etc. Our physiology might changes as uh, you know um, throughout the day, etc. So in the morning, our physiology very different than um, late in the evenings and at night, etc. Our temperature begins to change. Our cortisol levels, somatotropin levels begin to change. Well, sleep has various patterns. We go from non-REM to REM, repeating cycles, etc. And again, I just want to emphasize the importance of the core temperature dropping. Very, very important. That's why you should not exercise at night. Just my 2 cents there, because that drop in core temperature is so incredibly critical. So, if life in one word is about patterns, then I have a question for you. Why don't we measure patterns? And I'm going to ask you, please, starting tomorrow, when you ask for 0 to 10, simplest way of including the dimension of patterns is to ask your patients to do this. Give them a piece of paper and say, I want you to rate your pain morning, midday, afternoon, and at night. This is actual data. This is actually a patient's data regarding pain patterns. To me, looking at this, it just tells me so much. At one point in the day, pain levels actually drop. Why is that? And as we approach the later in the day, evening, etc., pain levels go up. So there's clearly a pattern here. It's not 0 to 10. It's 0 to 10 when. And once you discover, I treated a very complex case of burning mouth syndrome by just looking at these types of patterns. Why midday or pain, burning pain symptoms would get worse. So then you intervene. What do I need to incorporate at this point? Maybe you should wear your appliance. Maybe this is when you should use music. What use medication, etc. What happens at night? You're alone. You're thinking about things. You're worrying about tomorrow, etc. So think about patterns. So if you were to enhance sleep, do nothing else but improve a patient's sleep. This is why sleep is so critical. Um, by the time we go from week 1 to week 3, we see a significant drop. There's still pain. There's still pain, no question about it. But there's a drop in pain because we have improved the patient's coping abilities. That's what sleep does. Now, this is very important. Now, you have experienced this. You may not be fully conscious of it, but this is your patient is making progress. And this is when sometimes you feel like you're married to your patient. They're going to be with you for the rest of your life because patient improves, the symptoms improve, late phase improve, and as soon as you discharge them, the pain goes back up. They're back. Doctor is getting worse now. They have new symptoms, etc. Because, my dear doctors, you are a significant part of the treatment. It's important to know. So don't discharge patients too quickly. Make sure you give them a lot of tools, including your business card, instructions on the back of the card to help them remember the therapeutic relationship, the healing relationship you had with them. This is the good old Yalom, Aaron Yalom, the great, great Yalom saying, as termination approaches, patients are bound to regress, at least temporarily. I would add, at least temporarily. Sometimes I think they really regress because now they're going to lose you. So please keep that in mind. So think in terms of patterns. Please, please, I beg of you, don't just ask 0 to 10, but 0 to 10 in the morning, midday, just simple. Just look at four data points and graph this for yourself. Just a few days, a week of data provides you with a lot of information. Look in terms of patterns and also look in terms of dimensions of pain. What would be the other dimension of pain? This is the most important to me personally, is um, we are human beings. So my last few books I can show you. One has been translated in a couple of languages now. The most important aspect of our existence has to do with meaning. We are meaning seeking, meaning craving creatures. We create meaning, we look for meaning, we delve into different resources, ways of finding meaning. I'm just going to wrap look at my translation books up here. And I was asking when it was translated into Polish, I asked these people, I said, why are you translating why are you so interested in that? It says, people are looking for meaning in this part of Europe. And then a couple of years later, another book, this is Slovenia, I asked the same thing. Why are you thinking about translating? Why people are looking for meaning? Pain gets worse. It intensifies, becomes destructive when people conclude that it's meaningless. It's here just for me to suffer. Suffering may be related as much to the meaning of pain as to its intensity. If you recall, when we were in um, Spokane, I showed you studies by um, Henry Beecher, an anesthesiologist during World War II, who discovered that people who were severely injured required less pain medication than those who were mildly injured. And the difference was, I lost my arm, but I'm going to see my wife. I'm going to see my children. At least I'm going to see them again. They added meaning to their experience. Uh, so we need to be aware of the meaning dimension of pain or its lack. So we added another dimension to our cube, looking at meaning. Listen to your patients when they say, this is meaningless, this is horrible, why am I going through this, etc. Okay, I think I'm doing well. I have like 5 more minutes left. I'm going to use my other half of Xanax to make it through these next 5 minutes. All right, we can give meaning to our pain, and this is very important. And we can give meaning to our pain in different ways. So if we had time, I can tell you about patients who were absolutely convinced that their pain was a form of punishment. That this was life's way of getting back at them or God's way of getting back at them, which is very unfortunate. I mean, God, there's redemption. We can be forgiven. No, we don't forgive ourselves. So pain becomes the meaning of pain is my punishment. Or this is um, this is the more important thing we can do with pain. Yes, I'm in pain, and I'm going to be in pain for the rest of my life. But you know what? Now, self transcendence. This pain has made me more conscious of other people suffering, those who are around me. I have become more compassionate. Now, you have transformed that pain, you've given meaning to it. Now, I'm someone with severe pain who helps others, who comforts others, who helps them hold on to a sense of purpose or hope at least. So this is transformation of meaning. One should not treat the disease, but the patient. And to treat the patient, we need to look at we are integrated beings, meaning seeking, anxiety. If we are human beings, we are all is an important part of being human. Anxiety is always about the future. Again, I'm looking at I have 2 more minutes. I better finish this. So anxiety is always about the future. Anxiety is not a disease. It's not a disorder. It's being human. It's when it's excessive, when it's um, pulls me into a distant future, possible future with all kinds of imagination that I can conjure up, then anxiety becomes destructive. We need to gain control of our situation. So, and there have been many stories of people gaining control over the situations, people in the concentration camp, uh, Paul in the jail, etc. But regardless of what's happening around you, within you, there's a sense of freedom in which you can sing, you can pray, you can recite poetry, etc. So discovering that inner freedom is the key. So your patients have many dimensions, and the more of these dimensions you attend to, which you do with your gentleness, being with them, you are doing more psychological work than any other psychologist. I'm absolutely certain of it. I keep repeating that. I hope you're hearing me out. Um, don't lose sight of them. And today's everything is about science. Let's measure this, but suffering requires compassion. Yeah. To become a great physician, a healer, you must be aware of your own pain and suffering. Then you can have compassion for others. Life in one word, as I started this lecture, was integration, pulling things together. Death in one word, disintegration. So my suggestion is the more in your practice you integrate these different dimensions of pain, the more effective you are and the better you protect yourself. And we should start with you, actually. Otherwise, you don't get frustrated, drained, burnout because here I go again. I try this procedure, this procedure. The patient is not responding because there are these other dimensions that may be um, um, behind the scenes and affecting the pain, anxiety being an important one. So, if I may, I have one suggestion for the future of your wonderful academy, and my suggestion is become a role model. It's lovely to have an academy with all the membership. This is sweet and wonderful, but uh, if you start thinking, and I'm sure you are, but think more multidimensionally and start sharing that knowledge with others um, and educate them about them, then you are indeed making this a better world. So lead. Wonderful to have your membership, but now grow, add new dimensions to your academy through education, but most importantly, dialogue. Uh, and I think that is a responsibility. It's a responsibility. So help your academy grow by um, bringing a new dimension into understanding of pain. So don't think of pain as a flat surface, but think of it in terms of a cube. And the more you begin to see these other dimensions, the more you understand the why pain persists, why it's recalcitrant, does not respond, because if I want to punish myself, I don't want you to take away my pain. I come to you, but something in me says, no, you need to be punished, and that's a part of it. So that stops spinning, which means my final message is good old Emerson saying, please do this. In every work of genius, we recognize our own rejected thoughts. Uh, so contribute to life, add to life, continue to integrate, add other dimensions to your work, and teach others about it. And don't dismiss any ideas, plans you have, etc. Don't hide away your genius, and don't be frustrated when you say, "Oh, so and so is doing this thing that I was thinking about it years ago." In every work of genius, you recognize our own rejected thoughts. Good old Waldo Emerson, one of our greatest thinkers in the country. Here's my email address on the bottom, and please feel free to send me. Uh, that's amazing. It's right on time. Isn't it amazing? Um, so to give myself some credit, 8:50, and I finished the last slide. And I was telling Shay that it was so painful to keep removing slides. So I've removed quite a few actually this afternoon until so initially it was 120 slides, and now it's like 80, 86, very painful. But I'll send those slides to you as well. Great. I'd love to hear your questions and have a dialogue with you. Uh,
Thank you, Dr. Sadigh. That's wonderful presentation, and we appreciate it. We
sure.
do have a couple of questions.
Yes.
There is a request for you to talk more about how the doctor is part of therapy, its
Yes.
importance of the doctor touching them, their appliances adjusted by the doctor, and the difficulty of transferring to the assistant.
Wonderful. It's fantastic. Fantastic question. So, um, whether we like to accept this or not, um, when we want someone to fix our problems, and that's embedded in our unconscious, in our psyche. It goes back to a long, long time ago when our parents comforted us. They were in control. They could make us feel safe, etc. So the moment you, especially in a dentistry chair, in the moment the patient reclined, the moment you do that, the moment, especially when you go into their mouth, right there, you're regressing them. It's an immediate regression that takes place. And now you're not just the doctor and very knowledgeable, but you're someone whom I trust. And that trust, that sense of trust right there is the beginning of the healing process. That you're here, you're going to my mouth, and the way you're approaching me suggests that I can trust you. And trust comes out of um, consistency. You're doing certain things in a certain way. They're listening to you very, very carefully, especially as you get closer and closer to their face. They're listening, they're watching your eyes actually to see whether you're surprised or you're puzzled or your breathing begins. These are all subtle experiences, but healing begins with touch. And if you don't mind, I might just for a second become biblical throughout the Bible, beginning to healing always starts with touching. I was touched. Bless you is actually it means to touch you. You know, God bless you is God touch. So touch is a critical step that no instrument can achieve, no medication that can achieve, and we now know its mechanism. So another talk I can talk about this. When touch is comforting, immediately, almost immediately, your norepinephrine levels, your catecholamines begin to drop immediately. So you can actually measure it in terms of measuring beta amylase in your saliva. It just begins to drop. So touch is comforting. It's a healing touch. It's a warm touch. The research is a warm, loving touch, caring touch. Oxytocin levels go up, shoot up. So oxytocin being a pain modulator and being a bonding hormone, the most powerful neurotransmitter in the brain when it comes to stress is actually oxytocin. It was published in a paper 2001 by Shelley Taylor. So we are actually relational beings. We need to be touched, and when people avoid touch, or there's touch which is painful and being hurtful, etc. I'm talking about warm touch, the touch of a physician. And you can actually train your assistants to do the same thing. So the instrument that you're holding is held by your hand. And I would say, if I may suggest, and this may not be a correct thing, but before you use your instrument, please use your fingers. Like look at your palpating and then so I'm touching you, and you never touch something that is bad. So the moment you touch your patient, right there, there's an unconscious message saying, you're good. You're good. Right there. The are doing more healing work than you understand. And it's really sad that you're not aware of it. But maybe it's good. Maybe you don't want to pay attention. But I think it's good to know that your healing starts with your touch. And nothing else, no medication, no form of therapy. You are a huge part of healing the sense of, I'm not bad, I'm being touched, and you're comforting me, reducing my anxiety. When you tell them what you're doing, I'm going to look over here, just going to take 2 seconds. You're turning off my hippocampal network that enhances, exaggerates the pain impulse, pain signal. So right there, when you tell me that you're doing this, I'm just going to move over here. Just 2 seconds. It won't last very long. Just hanging there. Very good. The little distraction comforting me. You know what you're doing. Anxiety goes down. Pain becomes more manageable. I hope I answered your question. Thank you for doing these, by the way. You're doing these things and you're touching people. People are not 0 to 10. People are living beings, feel like uh, rejected, not wanted. Pain is bad. And here you're healing them in a most profound and beautiful way. Thank you. Keep doing it.
Um, as physical pain leads to mental duress, and mental duress leads to an increase of the intensity of physical pain, where is the best place to begin the treatment?
That is a beautiful question. And I will start by saying that for clinical purposes, for teaching purposes, we we dichotomize the physical and the emotional. Actually, the way your brain works, there is no dichotomy. The body and emotions are actually part of one whole structure. So one can affect the other negatively and positively. It's bidirectional. Um, Absolutely. When we are in pain, again, if it's knowable, the source is knowable. Of your emotions, their task is to move you away from the source of pain, to help you find quiet time, etc. But if it's unknown, you begin to deplete your resources. And I literally mean this. I mean this. And I wish I would get rid of the word depression. I've given presentations to psychiatrists and they agree with me. They shake my hand. It's a useless term. Depression is depletion. And we can literally talk about depletion of certain neurotransmitters, the levels of certain neurotransmitters dropping. We do see, for example, reduced serotonin availability that's in chronic pain. Um, GABA receptors are affected, significant changes in sleep architecture, again, due to changes in serotonin, excessive production of norepinephrine, creating all kinds of problems, acetylcholine levels. Everything is related. So pain will affect our emotions, emotions will affect pain. And that's why when you begin to treat depressive state, um, you begin to see changes in pain, actually in physical pain. Um, the body begins to withdraw when it cannot help itself, etc. And what happens to us mentally is immediately manifested physically, and physically in our somatic nervous system and the autonomic nervous system. That's why uh, there's an absolute strong correlation between uh, chronic pain and cardiovascular diseases, gastrointestinal disorders. Just look at your history and look for GI disorders. As pain persists, you have GI disorders as well. So they're both connected. And if you start working on one, you're affecting the other. If I'm in pain and you're touching me and you nice things to me. Look at what happens. I smile. I haven't smiled for days, and my eyes look at you very differently, etc. My body begins to relax. So dichotomizing has a place, but we're not dichotomized. We are one being that has these very different systems. Your heart is a mechanism, it's a fluid mechanics system. Okay, it's like fluid mechanics, and an electrochemical unit up there is your brain. They work beautifully together. They need each other from moment to moment. So the two systems may be very different, but deeply connected, deeply connected. Please, when your patient leaves, I'm begging you, today is everything. We are becoming artificial. Don't forget about artificial intelligence. Just pick up one of your cards that has your name on it and write down just a couple of notes. I want you to wear your appliance. I'll always see you next week. I assure you that it's called a transitional object. Will have such an impact on that, on your patient. I was going to call you, doctor, the other, then I looked at your card and said, I'll see you next week. It's like, oh, I can wait, etc. So healing is a multidimensional, incredibly powerful uh, phenomenon, and you're doing it. I just wish your if I may, as a professor, I can say this. I wish your professors had emphasized those areas. Having so many wonderful friends, especially in dentistry, they didn't emphasize the profound impact you have, especially on the unconscious mind. Thank you for that question. Any other questions?
Wonderful. No, that wraps up our questions. We have
Okay.
several comments just thanking you for the great presentation,
Oh,
and we
thank you.
certainly appreciate you taking the time to be here with us
My
today.
pleasure. Thank you for being here and keep making this a better world and know that your hand is the beginning of healing. And thank you so much for inviting me back. Uh,
Thank
Look
you,
forward
Dr.
to the next. My pleasure. Thank you, Shay.